As always, we'll start with a case. So a 62-year-old female with a recent renal transplant and remote history of pulmonary tuberculosis, status post 1 year of direct observed therapy, presents to the ED with 2 weeks of cough, a 20-pound weight loss, and a large upper cavity lesion on CT. A large infectious workup is sent, including 3 AFB sputum smears and MTB PCRs, and she has a bronchial alveolar lavage, which returns negative. The patient is discharged on empiric posaconazole. She returns 4 weeks later with fevers to 102 and persistent respiratory symptoms. The admitting team places the patient on airborne isolation to complete another TB rule out. So the question is, which of the following diagnostic tests is considered the gold standard for the diagnosis of active pulmonary TB? And your options are 3 AFB sputum smears, sputum MTB PCR, sputum AFB culture, or interferon gamma release assay. Can take a second to think about it. But the answer here is going to be sputum AFB culture. And we'll get into the reasons why that is now. So first of all, this question comes from my time attending on Team 7 at Ronald Reagan. I had a stellar third-year resident who was going into ID who asked the night admitting resident appropriately put the patient on isolation again, given the high pretest probability for TB to complete the rule out. And the question he posed to me, which I had to look up, was how good is the TB rule out? To answer that question, we first need to understand what is a TB rule out. And really, it's not a rule out so much as it is an evaluation for active pulmonary tuberculosis. And it involves collecting 3 AFB sputum samples approximately at least 8 hours apart. And according to the IDSA guidelines, at least one of those should be an early morning sample, right? Because that you pool secretions overnight, you get some nice juicy sputum, a lot of AFB, and you hack that thing up in the morning, it increases your yield. You need over 10,000 bacilli, 10,000 bacteria for a positive smear in a sample, and an adequate sample volume is 10 to 15 mLs. And you guys have all encountered the difficulties of getting people to make adequate sputum on the wards. And then these are sent for microscopy, which is the initial results you're getting, and then it is sent for a formal culture. So how good is that rule out, or how sensitive is that rule out is really the question there, the sub-question. The sensitivity of a single AFB sputum is estimated anywhere from 50 to 80%, more like the 50% range. The second sample will increase by about another 5 to 10%, but a third sample really only adds another 2 to 3%. And the IDSA reports that the overall sensitivity in all comers of 3 AFB smears, with one being an early morning sample, is about 70% sensitive for active pulmonary tuberculosis. Smears have a notably lower sensitivity in immunocompromised patients, particularly folks who have HIV, because they tend to have an overall lower burden of disease and have fewer bacteria in there when they do get sick, so it can be harder to detect. Importantly, an MTB PCR, which is automatically part of the order set at the VA, increases your sensitivity upwards of 90 to 96%. But many guidelines do note that a negative PCR, while helpful, doesn't sufficiently exclude TB if the clinical suspicion is high enough. So 3 AFB sputum smears that are negative are really reassuring that the patient probably doesn't have active TB, and if they do, they aren't very infectious. Thus, a rule out isn't really a rule out, but rather a risk stratification of how infectious that person is. And you can see from this table from the CDC that if you see no acid-fast bacilli, they are probably not infectious. And then they can be rated all the way up to 4+ disease, which is the rating system used. So the gold standard really is AFB culture. And this is because it's both sensitive and specific, 90 to 95% sensitive, 99% specific. You only need 10 bacteria compared to the 10,000 you need for the smear. The major limitation is that it takes 4 to 6 weeks to result. But Tyler, can't we just use a quant gold? And the answer is absolutely not if you're concerned for active disease. Remember that a quant gold is an interferon gamma release assay, and this is a test, this is the preferred test in latent TB. For somebody who's been exposed and infected previously. It is not valuable in somebody you're evaluating for active disease, especially if it's primary active disease, as it only has 60% sensitivity in active. And it can take anywhere from 4 to 12 weeks to turn positive after initial infection. So To summarize our acid fast facts, what is a TB rule out? It is a risk stratification of infectiousness. How good is it? It's about 70% sensitive for active TB. MTB PCR boosts it significantly. The best test for active TB is that culture, and you got to follow that up after the patient is discharged. And can I use the IGRA? Not if you're concerned for active disease. So we'll stop there, and I'll take any questions.
Hey, Tyler, that was terrific. Did your patient actually have tuberculosis on the risk stratification? I didn't say rule out. I was about to say rule out. I was like, no. On the TB
I still call it a rule out too, but I always explain to the team that it's not really a rule out. She did not. She had a second BAL and it came back positive for Aspergillus fumigatus. So she was treated for
that makes
invasive
so much
pulmonary
sense, because you would think if you have like that cavitary lung lesion that you'd be able to easily, identify on smear or PCR culture.
Yeah, great question.
Tyler, I was told that they hang on to the cultures for a long, long time, like up to 6 months. Do you have any, can you corroborate that?
Yeah, I think our ones at the VA aren't even reported until at least 6, maybe even 8 weeks. That's when you'll get the final culture results. I think they do hang on to them for a very long time, as they take a really long time to grow.
Thanks.
All right. Thanks, everybody.